Good afternoon, everyone. Welcome to the August 2026 VPS Research Spotlight. Today we have Dr. Samer Abu-Sultaneh from University of Indiana School of Medicine, where he's the professor of clinical pediatrics. And he is also the sub-chair for the Prevent Policy Subcommittee. Without going too much into his long CV, and to make sure that he has adequate time for his presentation, I think we'll move right on into the presentation. Samer, you ready to go?
Yes, thanks, Dr. Rice, for the kind introduction. Let me see if my slides go through. You guys see my slides?
Not yet. There they
What
are.
about now?
Got
Okay,
them.
perfect. Well, let me just make this small. Okay. Well, thank you very much for inviting me to talk about our study that was just published this year, talking about failure to wean predictors and adverse outcome for associated with pediatric post-extubation non-invasive respiratory support. See if I can make the slide work. Okay. I have no disclosures. So for introduction, we know that we use post-extubation non-invasive respiratory support, and from now on, I will call it NRS, is used to maintain adequate respiratory function, so to prevent reintubation. In the last 2 decades, what we notice that there is increase in use of post-extubation NRS use, especially high-flow nasal cannula. So if we look at the study that was published by Jeremy Loberger also recently, we can see that here in the lower graph that our extubation failure rates in this multicenter database, that the extubation failure rate at 48 hours and 7 days, you can see that they are steadily declining, but not by the rate of NRS use. You can see how high is NRS use, especially after 2017. We tried to figure out where the signal is coming from. As you can see, this in blue line, that BiPAP use, there is slight increase in the BiPAP use, but the most increase is from high flow nasal cannula. Again, this is when 2017 year, like there's a big jump that is continued to increase with time. As we remember in 2023, the vent liberation guidelines was published, and it had 15 recommendations regarding to different aspects of ventilator liberation. Regarding NRS use post-extubation, it recommends to use NRS of any form for patients with high risk for extubation. And if you extubate a patient to conventional oxygen therapy, and patients start to have more distress, it recommends to escalate to NRS before trying to intubate. And it gives a specific recommendation for patients below 1 year. And this is coming from the data coming from the first ABC study. For patients less than 1 year, it recommends, if NRS is used, use CPAP over high flow. It doesn't give a lot of recommendation regarding patients above 1 year, just because there is limited literature to support any of the forms superior to another. So when we talk about using post-extubation NRS to prevent extubation failure, we're adding another outcome that is important for vent liberation. We always talk about historically that we try to prevent extubation failure and decrease IMV duration. But now, with this increase of post-extubation NRS use, we should pay attention what's the rate of post-extubation NRS use and for how long we keep these patients on NRS. So little is known about provider practices or trends of using NRS, especially when we talk about increasing complexity in our patient population in different PICUs. So for this study, we had three aims. We want to describe post-extubation NRS use and look at variation based on some patient clinical variables and also based on institutions, and try to identify factors associated with failure to liberate from NRS at 48 hours. This is an outcome that we introduced in vent liberation, trying to mimic it to extubation failure at 48 hours, and explore the association between post-extubation NRS or failure to liberate from NRS and patient-centered outcomes. Our hypothesis is that there is a wide variation of NRS use between patients and also between institutions. And risk factors for failure to liberate from NRS will mimic those for extubation failure that we published in previous studies. For this study, we use data from VPS. It was a retrospective analysis. We included patients, pediatric patients less than 18 years of age, who were intubated for at least 24 hours. And we included the first extubation attempt. As you can see here, we included a decade from 2013 to 2022. And since VBS doesn't have the intention of this planned or rescue NRS, we use a pragmatic definition of planned NRS if it is deployed within 30 minutes after extubation, and if it was deployed after that, we will consider it as a rescue NRS use. Our primary outcome was failure to liberate from NRS at 48 hours post-extubation, but we had other secondary outcomes like post-extubation NRS duration, extubation failure both at 48 hours and 7 days, PICU length of stay, hospital length of stay, and PICU all-cause mortality. For statistical analysis, we use logistic regression model, depending on if there's a categorical or linear regression for continuous variables there. For results, our table one, as you can see here, it showed the patient population. We included more than 132,000 patients. For the forms of NRS, you can see here in the table that high flow is the highest use of all of the three, followed by BiPAP and then CPAP. And usually it's deployed as a rescue modality rather than planned. Now, for the high flow and CPAP is used more in younger patients, and BiPAP is used more for older patients. Now, if we look at how people use NRS, they use it as a rescue if there is extubation failure risks, as you can see with all of the three modalities. And they use IMV duration as a factor to plan NRS use for the three of them, as you can see here. This is what we call Sankey diagram, and it looks at progression of post-extubation NRS modality from the initial modality or respiratory modality used, and every 24 hours up to 7 days. And you can see there is two important things. The first thing, that room air or conventional oxygen therapy is the most common modality that's used. And by far, it has the most escalation rates. As you can see, these lines where these room air conventional oxygen therapy, you see how big or thick the lines are moving to high flow CPAP, BiPAP, and reintubation. For high flow nasal cannula, usually it's weaned gradually, especially in the first 72 hours. But CPAP and BiPAP, they are slowly weaned. And you can see that, but if you follow this, like for example, the BiPAP, the green line, how it's the thickness of the line, how it goes from day to day. Now, we looked at the post-extubation NRS use based on institution, and we divided the institutions in three categories based on patient's volume: low, medium, and high. This is for high flow nasal cannula. You can see we divide them further to planned versus rescue here. You can see there is not a lot of variation based on institutional volume. CPAP, it's a lower use in general if you compare it to, as we said, compared to CPAP and to BiPAP and high flow, but there's not a lot of variation. BiPAP, there's a slight increase in the high category there, but it's not a huge degree. As you can see, there is 10% versus 8% here combined. So there's not a lot of variation based on institutional patient volume. Now, we looked at logistic regression to look for factors associated with failure to liberate from NRS at 48 hours. So the odds of failure to liberate from NRS was higher with advance in the study period. We divided the 10 years into 2 years epochs, and you can see that how the odds increase with time. Also, if the patient has one of these diagnoses for high-risk diagnostic categories, and these are cardiovascular, renal, respiratory, and ENT, and this is from our previous publication that I mentioned before, that was published in CHEST before. And for modality, you can see that the odds increase from high flow to CPAP to BiPAP. The BiPAP is the highest from the 3 modalities. And IMV duration also increased the odds of failure to liberate from NRS. Now, older patients also have higher odds of failure to liberate from NRS. Now, we looked at the outcomes that of interest, and we looked at the patients who were able to be liberated from NRS within 48 hours versus the one that they didn't. And you can see in these the 4 outcomes that NRS length is higher in the patient that failed to liberate from NRS at 48 hours, PICU length of stay, as you can see here, hospital length of stay, and also mortality. Now, we looked at the duration, total duration of NRS, and it mimics a lot of failure to liberate from NRS at 48 hours. The duration increased with later years, also high-risk categories, as you can see here. It's interesting that you can see that planned versus rescue, that the planned, any modality of the 3 modalities, the planned use of that modality has a higher duration compared to the rescue. And IMV duration, you can see as you increase in the IMV duration above 7 years, it increases your NRS use. Now, we expanded more to the secondary outcomes, extubation failure. As you can see here, that the odds of extubation failures, similar to other publications, that younger age, they have higher odds, especially when you talk about neonates and infants, patients with high-risk diagnostic category. And if you use CPAP or BiPAP, especially when you use a rescue modality, and IMV duration above 7 years. Now, interestingly, in this analysis, that high flow use lowers your odds for extubation failure. Maybe this is more of selection bias of what people are selecting what device based on the risk of patients for extubation failure. When we looked at the similar data or similar analysis for failure to liberate at or extubation failure at 7 days, you can see that we have this similar trends, that the odds are higher in younger patients, and also if you use a BiPAP or CPAP, especially when you use BiPAP as planned or rescue, and IMV duration above 7 days. So we concluded from the study that post-extubation NRS use was mainly affected by patient factors rather than institutional volume. Failure to liberate from NRS at 48 hours was associated with worse patient-centered outcome, as I showed in the table. And what we need to work on is optimizing the use for post-extubation NRS deployment. Which modality we should use, for how long we use it, how we can wean these when the patient is ready, and trying to optimize that, not just at single institution, but more at different institutions. And just a commercial break here. We have the VentLib for Kids collaborative there, trying to implement the vent liberation guidelines. And we have a PICU arm and ICU arm. And now we are in phase 2 and trying to stratify these patients in a high risk and low risk. And with that, trying to optimize the use of NRS for those patients. And with that, I'll leave my contact information there. And I'm happy to take any questions.
Thank you very much, Samer. Let's see if we've got any questions coming up. I'm looking and I don't see anything yet. While we're waiting, I have a question that I missed in your methods. Two things. One, did you include those that went on to have just a longer duration of NRS before they were successful? Or did you also include those that had to be reintubated after the 48 hours?
Let's see. So we just I didn't include that in my slides, but if the patient, maybe just share the slide here. Let's see if I have the information here. Yep, I think I have it here. Maybe just read it very quick. So for these patients who failed extubation within 48 hours, we excluded them from analysis regarding failure to recuperate from 48 hours and post-extubation NRS duration, because we thought that this will be a confounder. So we excluded them from the primary outcome.
Great. And one more question. How did you handle those that got escalation post-extubation? In other words, whether they went on to, maybe they started out on high flow and then they failed that and went on to progress to CPAP or BiPAP. How did you factor that in your analysis?
So we counted them as any NRS.
Okay.
And we just, if they're like high flow, if we have them as a high flow duration, we just combine the high flow duration, CPAP duration, BiPAP duration.
Yeah. All right. It looks like we've got some questions, but I'm not able to bring them up. I need help from my helpers. Alex, Vanessa, somebody, I'm not seeing them. Oh, I got them open now. So it looks like Elaine from up in Canada. She's asking, what was the percent of patients who had extubation failure at 48 hours? You only presented the odds ratio.
Yes, and this is part of our previous publication. And our previous publication, we showed about 8%, is like 8.1% extubation failure in the last decade at 48 hours.
Okay. And Gerardo had said, I believe you mentioned planned has a longer duration than rescue. Do you think that's due to some bias?
Yeah, I think this is the big thing. Like, I think lack of wean. Like, if I'm planning to extubate a patient to a BiPAP or CPAPs, like I would keep them longer before I start weaning them because I thought that they would need it. So I think that practice gap, I think we need to work on in the future because people are not weaning as fast as they should because they thought the patient needed that support.
Yeah, and I see, Gerardo, did that take care of your question? I hope so. I have another question coming from Catherine Rice, who's a RRT. She says, great work and presentation. 2 questions. Do you have any hypothesis about high and low volume centers which have higher use? And number two, apologies if I missed, what are the high-risk patients definition?
Yeah, I maybe need a clarification about the first question, but second question from our previous publication, maybe share the slides again. We studied patients' risk factors to see who is at high risk for extubation failure. And these are the three categories there, which is cardiovascular, renal, and respiratory, or ENT, but also for age, IMV duration above 7 days, and also age below 12 months, were the highest patient population for extubation failure.
Yeah, I'm going to try to clarify her question in the way that I read it. Maybe if it's not clear, hopefully she'll add on to it. I think she's asking about, do you have any hypothesis about why there is a higher use between the low and high volume centers?
Regarding high flow or BiPAP, maybe I'll explain it. Maybe for BiPAP, we think that even that slight increase might be related to patient complexity. The other factors that we didn't study, but this is something that it's good to look at, availability of devices. So as we know that there's comfort of using CPAP and BiPAP, depending on the patient's experience, or not patient's, provider experience with that. So do they have available masks for different age? Do they have a protocol for that? Do they have devices that have a better synchrony? So it's more of comfort, maybe patient complexity. Now, I think I'll leave it for you, Dr. Rice.
No, go ahead. I'm sorry, I wasn't trying to interrupt.
So for the high flow, I think maybe there is a slight increase in the high flow use. As you can see, the numbers a little bit up in the low versus the other two categories. Again, it's not statistically significant, but it's easier to deploy. It's available everywhere. So maybe the smaller centers, they find that their patients, would be easier placed on high flow, and would be more comfortable rather than trying to put them on BiPAP. So this is my two explanations: experience, availability of devices, and maybe patient factors too.
Yeah, I'm curious, Samer, if you would look at it, if you'd look at the same data, only look at it between the different types of ICUs, the community versus the tertiary and quaternary. And then the other way you could cut it would be to look at those freestanding hospitals compared to the others. In the past, we found some differences in some of the outcomes in the freestanding children's hospitals. That was before the 2018 redo of the guidelines or suggestions. So I see there's a whole bunch more questions here. I should get to them. Chris Dubinsky, how did you handle patients who were still on high flow when they were discharged from the ICU?
Like for the duration. So if the duration for high flow, because will be the two outcomes that we mentioned. For duration, the end of the device would be time of discharge. So we will cut it at the time of discharge.
Right. So even if they went out of the unit at 24 hours on high flow, you would cut them off because you don't know what happened for sure out on the floor.
Well, we took any duration. Yeah, exactly. So if they went out, that's it. Like, since the VPS is just the PICU data, we just cut them off at that time.
Right. Another question from Nina at Feliciano. Not a question, I guess, but I just want to comment on how impressive the Sankey diagram is for visualizing the data. Thank you.
Thank you. I love Sankey diagrams. We use them a couple of times in a couple of applications. Just good visual, addition to show how the patients flow from one end to another end. So thank you very much.
Another one. What are the implications of this study in the long-standing debate of high-flow nasal cannula versus other non-invasive support in respiratory failure?
I don't think that would solve it yet. I think it will give us, more, more, background and support that we need studies. Is that right? So I think, if you look at the big studies, when we did the analysis for vent liberation, there's not a great studies comparing even high flow to BiPAP, especially with older patients, with more complex patients. So um, we maybe I just try to guide the team to another publication we had regarding research gaps and vent liberation. This is one of the RCTs that we would suggest to for us and other people to do to compare this for the high risk patients because we don't know. I think the first APC study was a great study, but compared just high flow to CPAP. Um, I think before that, we need also during the, any RCT, if we build an RCT, is escalation, de-escalation pathway. Make sure that we have for all of the sites that they will do, if we do multicenter RCT, make sure that, comfort and availability of different masks, of different devices, um, standardize the sedation protocol when you are on non-invasive respiratory support, especially BiPAP and nutrition. So a lot of elements maybe need to be standardized for the protocol, but I think that will bring a lot of work for us to do. Still, we are doing more studies with vent liberation to study the behavior and outcomes, if we need to adjust any of our interventions. But I think the ultimate question would be answered with multicenter RCT on the high-risk patients.
Thank you, Samer. I think I've pretty much exhausted the questions unless somebody else is typing. Uh, I think that was a very good, concise presentation of a lot of complex data. Okay. You might
Well,
want to comment on, do you have any feedback on the analysis and problems or barriers you and the rest of the team ran into in trying to sort out the VPS data that you had?
I think that we worked with VPS data before with different studies. I think it's very comprehensive and a great source for information. Many of the respiratory um, diseases, devices, support. We did it for different things. We did it locally and also in a multi-institution kind of studies. I think we are used to it. We are appreciative to the VPS team, giving us the data in a way that we can easy analyze. It's a great data. A lot of patients has a lot of granular data. Uh, there is other, just to add to the limitations, other things like complex chronic conditions that we couldn't include the way that we like just because of lack of ICD-10. But I think the future is coming as you guys, are working on integration of VBS and other data sets. I think that will enrich the databases and make our work more robust with these patient populations.
Yeah. Well, thank you very much. I would add that the VPS has had a task force working on the complex patients, and hopefully we're going to come up with some more accurate definitions so that we can pull that information uh, out of there. And I would say another thing that you and some of your colleagues brought to our attention a year or two ago is that our basis for high flow was based more on age than on weight until the consensus criteria came out. And so VPS is changing that to hopefully get a little bit more detail for you and the other people who are interested in studying the non the NRS data. So again, Thank you very much. I really appreciate your work and your presentation today. And I thank all of the rest of the people who joined us today for this. And hopefully we'll see you on our next uh, spotlight. Thanks
Thank you very
to
much.
everyone.
Appreciate it.
Bye, Samer.